All right, now we're going to look at the aging population. So I gave you some statistics in that first chapter, but we're going to even go farther with this. We're going to look at the economic and social issues. We're going to look at aging across different cultures and look at how we're aging differently now than we did in the past. And really what we want is successful aging. Remember, ageism is that very negative term. So we have a lot of great terms that we use when we talk about the older population. We look at things like aging in place, the chronic disease, the demographic tidal wave. What that's meaning is here they come, that the baby boomers are here. We are the first group that is living into their 80s on average. I mean, it's just amazing. We're looking more at foreign born. They also call it the graying of America. The pig and the python. This is where we get a big bulge in the population, which means our elders are moving forward. And one of my favorite terms that really exploring gerontology is the silver tsunami, is that it's just a wave of gray. And I just think that's a really great analogy. So there's different key terms throughout this chapter in the text that we'll be talking about. So as I tried to introduce you to, we look at the people, real and projected numbers. This is from the Census Bureau, and these are projections up through 2050. So if you even look at where we are right now, those that are 65 and older is quite large, and as you'll see, that's where it's starting to creep and peak, and it's just amazing. And as I said, 86 for women right now. That's a long time to be living if you're at 65 years of age. So as we look at this aging population and the increased life expectancy, what's contributed to that? Well, obviously sanitation's improved, but we're still in a rural area and people can be without power and without water. And if that's where they're living, we need to be sure that even sanitation is taken care of. Major advances in medical care, preventative services, Medicare, Medicaid. The insurance carriers are all looking from a health promotion and preventative point of view. What used to be fatal is now totally livable with most of our chronic conditions. What I find is amazing, and why the importance of the geriatric nurse specialist is a general entry-level nurse, is that the average 75-year-old has 3 chronic diseases and takes a minimum of 5 medications. And those medications can affect these different diseases. So it is such a fine check and balance that polypharmacy, as we'll be learning about, is one of the things that we actually call a geriatric syndrome. They're at risk just because of multiple medications that they take. So as a population, as we look at 2010, 23 million older women versus 17.5 million older men. Just seems that historically that we have more women than men, and women outlive men. 4 times more women than men are widowed. And in 2010, what we knew that 72% of older men were married. Well, only 42% of older women were married. And again, looking at those ages, I just think that's precious. These 85-year-old plus 15% are still married, and then they've been married probably 60, 70 years because they got married so young. Divorce just wasn't an option back then. Income, what's really changing because our distribution is changing. This becomes important to understand with the political environment. We look at Social Security used to be our major source of income, and I'm 51. I can't plan on Social Security really being there for when I plan to retire. And again, I'm at the end of the baby boomers. My year is the last year of what they call the baby boomers, and that money just isn't there, and my focus is shifting now on pension. So that distribution from 62 to 2008 show how things kind of stayed kind of true, but Social Security was always the same. It's not going to be in the future, and this is really what is changing. The thing that's changing also with our aging population is they're educated. They are more educated. They have better incomes overall and a better state of health because we've had insurance policies. And in the 60s, we really started a lot more with health promotion earlier on in those advances. High school graduation rates are much increased. If you look in our community right now and take our 80-year-old population, many were not high school graduates, especially, if they were on the farm, and they're lucky if they had a GED. And as like the boomers of my age were high school diplomas. Most of us have some college education, so we can understand things better. We are still unfortunately seeing quite a variance still with ethnic groups. Hispanics, some of the first generation, we have a lot of Hmong, but those first generation, it's their children here that are first generation college students. So you just have to also know who your population is. But really, when you look at this, the more educated people are and have been self-sufficient, the less dependent they want to be on others. And that can really further depression. So you have to look at it and know your client from a point of view. Living arrangements, can they afford where they live? Do they have private caregivers? Unfortunately, I don't know your stories, but I look at my own mother, who was very well educated and who had a wonderful insurance policy, was able to have hired caregivers in the home, which allowed us not to have to put her in a nursing home. Those policies are getting much rarer. They were very expensive, but they were good for a while. But 55% lived with the spouse till 2010, and the likelihood again, 47% of women are only married. That means they're living alone. What is amazing is that the number of grandparents that are 65 and older that are now taking care, primary responsibility of their grandchildren. That's a big shift. You're looking at these parents, divorced kids, and grandparents are now raising their children. We used to put kids up for adoption. You're seeing a little bit of that becoming less and less, and the grandparents raising their grandchildren as the primary custody holders. What we do know is that white Caucasian, probably about the year 2030, they're estimating, which really isn't that far from now, that the white Caucasian will no longer be the majority. And that we have to look at that ethnic minority elders will be 42% of the population coming up, so in the next 40 years. So it again is, we have to learn to adapt to different cultures, to different traditions, to different norms, to really meet these needs. Health problems also, because we know the genetic component of many things, health problems really change related to race. African American are known to have higher incidence of kidney failure with diabetes, and Native Americans are probably the highest risk just based on genetics and ethnicity for diabetes. So again, who's your client? We each have our own. Again, of those other minorities, we have to look at foreign-born who live here, the veteran. The other big thing that is changing, two areas that are changing so much, is the aging disabled population. Group homes are becoming less and less. There isn't money to fund them. And also inmates, prison population. Prison nursing is huge outside of Marathon County because we just don't have a lot. But you have to think of the age of those inmates that are in prison for life and went in as young men and are going to have a lot of chronic conditions, and how are we going to manage that. The other thing that we want to look at is mortality and morbidity across the chronic conditions. And as you'll see, looking at it from a men and women perspective, and as you'll see with women with hypertension, heart disease, actually this is old statistics, which is from her book, but heart disease overall is the #1 killer of women. We're more silent in our symptoms, and we can be talking about that. But as you'll see, what we're looking at is the chronic conditions is we need to become the experts and that resource for evidence-based practice with hypertension, heart disease, more than not heart failure, stroke, asthma, COPD, generalized cancers, diabetes, and arthritis. So we're multifaceted, but as you can see, these are more the chronic illnesses that can all exacerbate. As I was just saying, as you can see, heart disease 30%. So as we move forward in healthcare and learn more about health promotion, we want to grab our population when they're younger to prevent those problems of heart disease and stroke. The greatest thing I heard is that actually smoking is the lowest it's been. I think it's because of the cost of cigarettes. But hopefully we'll see a decrease in those lower respiratory diseases. What we are going to see an increase in is diabetes. And the other thing that we're learning about Alzheimer's is the correlation between heart disease and diabetes. So we'll be talking about that when we get into our disease states. And I will bring in the latest and current literature on that so you're updated from the time you've taken the course. So again, looking a little bit at the history in the pre-1900s, we said people were old at 60. Well, my 76-year-old dad plays golf 3 days a week and jumps out of airplane once a month. He's not your average 76-year-old, I guess. But as we look at what we even call old, well, if you only lived into your 40s, 30s, and 40s in the 1900s, 60 was considered old. We've lost respect of our elders, and old age was considered a privilege of the rich because we didn't have health care. Florence Nightingale was just coming around to let us know about being healthy, but it was President Theodore Roosevelt that really established old age as a true disability and gave money to people, because that's where we got our Social Security Act back in 1935. Which seemed like a great thing at the time, and all of it was right, but it no longer fits our population today, and that's why there's so much discussion in the political arena about this, and that it's not gathering the funds and it's spending funds because we're living longer, and we didn't adjust for it along the way. So again, today, 55% of persons 85 plus in the U.S. are impaired and required long-term care. That is over half. That's amazing. But the good thing is a majority of those adults are like my father. They're healthy, they're active, they're actually having wonderful retirements. What we want to see, though, is that definition of an aging in place. We want you in your own home, independent, regardless of your age, income, or ability. You do better at home. There's no doubt about it. We can give the best care in nursing homes and in assisted livings, but it's got to be home to them, or we don't do well. We also need to be those advocates again on services available, how to prepare for retirement, proactive measures. We've got to do better earlier to get there. Today is all over the buzz right now. Is you look at students that are graduating with this multitude of debt. How do they start saving for retirement on their first job, as maybe our parents did, or your grandparents, when they're paying off student loans? So I think we're going to really have to prepare for retirement much differently. And again, as someone in her early 50s, I've had to reconsider my plan for retirement. And I think I'm pretty young. So, in summary of this, it is these baby boomers that we're talking about that are really affecting our society right now. We are seeing great health disparities among minority elder groups, which up here in the Northwoods you don't see. But I've been very blessed to be able to travel within a job and see healthcare in New York and in bigger cities and see the disparity just from an ethnic point of view. And we want, when possible, lifestyle choices. So that's just another review to set the stage for what this course is about.